All right, thank you, everybody. That was a very nice introduction, more than I deserve. Thanks for braving the storms. I hope your houses are not too destroyed. I was blissfully unaware that it was even coming as we were landing, and we just landed, and I took the taxi, and then all of a sudden the Amber Alerts started going off. I had no idea any of it was even happening. So I hope everyone went through okay. All right, today we're going to try and spend 40 minutes or so talking about the tricuspid valve, which is a daunting task, to be sure. I wanted to make kind of a 21st century homage to the forgotten valve idea, though honestly, with the way the FDA is treating tricuspid therapies these days, I'm not sure they can really call it the forgotten valve anymore, given how quickly everything's been approved. But we'll see what we can do. Here are my disclosures. And the agenda for today, what I'd like to try and do, if I might, is spend a little bit of time contextualizing what we've known about the tricuspid valve, some of the observational data over the years, talk briefly about the guidelines. That's the moment that everyone starts to snooze, so I'm not going to spend too much time there. And then look at the surgical antecedent, since a lot of what we do in structural is basically just try and copy what surgeons have already successfully done, though it might be a little different in this case. And then spend kind of a bit of time on trying to understand these new transcatheter therapies. There are now commercially available products, but I think there are more questions than answers around case selection and how we kind of move forward. So that's the agenda. And so let's start with chapter 1. So not every county, Olmsted County does not reflect every place in the country. And I think that much is clear, but that is where a lot of the population data comes from, where they just do sort of screening echoes on everybody. And so in Olmsted County, the burden of moderate or greater tricuspid regurgitation in the general population is about 0.5%. If you extrapolate that to a US population of around 330 million, you're talking about 1.8 million people in the US who have moderate or greater severe tricuspid regurgitation, just sort of back of the napkin numbers. If you look at the number of isolated tricuspid valve surgeries performed, we're talking about very small penetrance of surgical isolated tricuspid valve therapy. So that is the sort of first context clue about whether or not the tricuspid valve is important, is like, frankly, the surgeons haven't seen it as that important for a long time. Now, that may be changing, but that is just the reality of where we've been. And for those of you younger in the room, you may not recognize this person, but this is Francis Fontan, a well-known surgeon. You could say, well, he didn't really think that the tricuspid valve or even the right heart was all that important, right? I mean, he bypassed the whole thing. And I do want to call out, obviously, that this is not a conversation about adult congenital populations. They are different physiology. Being born with something is very different than sort of acquiring a dysfunction over time. So not really the population that we're addressing, but point remains that there have been historical precedent to just kind of ignore the tricuspid valve. And if you want to take it to a step further, as was mentioned, valvectomy is a thing. And I have to admit, I didn't really even know this until a few years back, that there have been studies particularly for endocarditis, where people just cut the valve out, throw it away, and sew the chest back up. And so now you're talking about one of the most hemodynamically difficult scenarios to come off cardiopulmonary bypass with no valve at all. And people apparently do okay, right? So another sort of clue that, well, I don't know, is it worth anything, this tricuspid valve? People have just been throwing it away. And this, by the way, is not just one wild man, right? This is a meta-analysis of valvectomy. And this, not published in like the Gerald Ford administration, this is published in 2019, looking at just throwing valves away and leaving you without one, presumably to to get your life right and then come back and get a valve later. But and the outcomes of the trials are not that important. They're not terribly great trials. The point is that people have been kind of ignoring the valve for a long time, right? On the other hand, touchy. On the other hand, you have observational data that started to show up, right? This is Tel Aviv looking at patient-wide echoes across the city, lots and lots of patients, as you might imagine. And they found that there was a kind of that the degree of tricuspid regurgitation tracked with mortality over a 5-year span, right? And the solid line is no TR, and you can imagine that as you work your way down, you go from mild, moderate, and severe. So, and in that model, they adjusted for a lot of the things that you'd want to adjust for as best you can, you know, MR, left-sided heart disease, diastolic dysfunction, PA pressure, et cetera. You can read the list. So, so there's a clue that actually maybe the tricuspid valve is more important than we thought it was. But you could rightly say, well, this is observational data, right? And maybe someone is septic. They show up to the hospital in fluid septic shock. They get 11 liters of fluid for volume resuscitation. Now they've got wide open TR. Someone gets an echo in the hospital. The person dies because they're septic. And now you have an observational association between severe TR and death, right? It's not causative in any way to sort of to look at these data. So the authors did try and address that. They said, okay, we're going to exclude indexed echoes that showed tricuspid regurgitation if it was performed in the hospital. So now we're just talking outpatients, right? And what they found was a similar kind of correlation between severity of TR and mortality over a 5-year span. And in fact, the hazard ratio for severe TR leading to death was more pronounced if you were in the outpatient setting than it was if the index hospitalization was included as your first echo, right? So, it's observational data. It is what it is. But this would suggest that maybe tricuspid valves do play a role in patients' mortality. That is the idea. So we're still left with this issue of the construct, right? Is this RV dysfunction that ultimately leads to progressive TR, that leads to volume overload, that leads to worse RV dysfunction, or is it actually the tricuspid valve? Like, how do we peel these things apart from one another? Which is an important question as the world of dedicated therapies for tricuspid valve explodes, because if it is fundamentally the RV that is the problem, let's say, then addressing the tricuspid valve may not do that much, right? What's left out of this, by the way, and I want to table the comment and bring it back, but what's left out is the right atrium. And I do think we've overlooked the role of the right atrium in severe TR and atrial functional TR. But anyway, this is sort of the classic construct. And so when you look at TR by sort of, let's call it root cause or what's associated, most TR is secondary. I think that doesn't surprise anyone. You don't see a lot of myxomatous tricuspid valves. You don't see a lot of torn cords or flail leaflets as you do on the mitral side. It's predominantly secondary to something, and that's the sort of the 93% in blue, and then you can see it's broken down by all manner of secondary things. What's interesting, I think, is if you look at primary TR, most of it is described as being device associated, meaning pacemaker or ICD lead associated. And that's an interesting population in one way, which is that it does kind of, it might, I guess, speak to chicken and egg. Okay. Because with lead associated TR, you didn't have it before you had the lead, right? And then you have kind of a point in time which someone introduces this thing that creates the TR, and now you can follow these people forward. This is the only study I could find on this, but this is a single center study. It's a population of patients who had an echo before they got their cardiac device and had no TR. and then they got a cardiac device and had a subsequent echo within 6 months or so, or actually 1 to 18 months after their device was implanted. All right. And then they broke up that subsequent population into had new TR or didn't. Now, there's a caveat to this, of course, which is that maybe you have discordant pacing and you could create TR in other ways. But for a second, we're going to assume that most of the TR created was because the lead was across the leaflets and thereby introduced new TR. Okay. And what you saw in the the new TR population was that they had an increase in RV size, an increase in RA size, an increase in PA pressures, and they had new TR. And if you follow these folks, you start to see that the mortality curves separate among the new TR population in about 3 years' time, whereas heart failure and mortality come up right away, right? And so this is maybe some observational indication that the introduction of TR drives RV dysfunction, right? RV got bigger, and in turn also drives this mortality finding that may or may not be true. It's all observational. But so I think that this is kind of an interesting paper just because it sort of does speak to whether or not the TR itself is a driver of poor outcomes. All right. So let's switch to guidelines and grading for a minute. Okay. So I think most people have seen this, the augmented TR grading system. Becky Hahn put this out as a manuscript after the SCOUT-1 trial. SCOUT-1 was a pledgeted suture device that was delivered via transcatheter approach. And essentially in that trial, what they found was that they could drop the vena contracta substantially, but still have severe TR. So they made new categories of TR to say, like, look, we've gone from massive to severe, and so we're successful. My point in showing this is actually just a single point, which is that this center might be exceptional at this, but quantitative assessment or semi-quantitative assessment of TR in routine practice does not happen. And that is fundamentally one of the things as we look towards treating TR or thinking about treating TR, we're not even really good at making a diagnosis of severe TR, right? I mean, at least at most of the places where I get referred TR, the way it's diagnosed is post thumb lick. It's like, you kind of do this. And that's okay, but we do need probably to figure out a way to get a little more discrete in our information and our understanding of these patients. These kind of, vena contractas, EROAs, 3D vena contracta areas, I just don't think they're happening on routine surface echocardiograms. And that also creates some issues for evaluating the success of any therapy to follow if you don't totally understand where you're at to start. In terms of TR staging, I've never found this terribly helpful, but there is a staging mechanism that's been proposed by the ACC and AHA. Essentially says stage B is at risk. They have TR, but the right heart is normal. The venous pressures are normal. Stage C has no symptoms, but you start to see elevated pressures and enlargement of the right heart. And then stage D is when sort of symptoms manifest, particularly dyspnea and fatigue. So in my current practice, I do a tricuspid day a week. Every Thursday, I do tricuspid valve intervention. I typically do 3 tricuspid clip cases most Thursdays, and have since 2018 because of a weird ability to get those paid for in the state of Washington. And I will tell you that if you start asking 80-year-olds if they have fatigue, guess what the answer is, right? And so discriminating stage C from D is an awfully challenging thing to do. In terms of medical therapy for tricuspid regurgitation, it's pretty sort of common sense. Diuretics may be useful is the exact language. And if it is secondary to something, try and treat that something. Those are both 2A expert opinion recommendations. There's no mortality benefit. that has been shown. The guidelines, to their credit, predated sort of the newer GDMT agents. We don't know much about them in the context of severe TR. So that is an open question when it comes to medical therapy. But standard heart failure regimens and sort of old school GDMT don't play really any substantial role, at least in the guidelines, when it comes to tricuspid regurgitation. It's just wring out the sponge. All right. Treatment. So the treatment guidelines are all about surgery, right? There's only, all of the guidelines are level of evidence B and non-randomized data. There are observational data. The only class 1 recommendation, as you all well know, is to fix TR during a while you're fixing a left-sided valve. There are some other 2A recommendations that are also non-randomized data, though this did come out a couple of years ago. This is currently a 2A recommendation that offer annuloplasty of the tricuspid valve for moderate or less TR when there is annular dilation while you're in there for a left-sided valve. This study at 2 years did not demonstrate a whole lot of difference, certainly not mortality. There was less TR, and so maybe with further follow-up, we're going to see the curve start to separate. We'll see. And there is no quality of life difference, at least in those first 2 years. So, a lot of the space around surgical intervention is still actually it's been done for a long time, at least a little bit, but it's still actually being worked out as to the value proposition. The European guidelines differ in one way. They give a class 1 recommendation to isolated tricuspid valve surgery if there is no RV dysfunction. Again, not based on any randomized trials, just a kind of expert opinion, level of evidence C. And the tricuspid valve got 1 page out of the 52-page valvular heart guidelines from Europe. So it does go to show you sort of how much work has been done in this space up until just recently. All right, so let's move directly into some of the data around surgical therapies. As I mentioned, a lot of structural heart is just structural interventionalists chasing surgeons around and using their kind of antecedent data and understanding of valvular heart disease to decide what to do. This is Medicare billing data in the United States. So therefore it is older patients, right? Because you have to qualify for Medicare. And what it showed for isolated tricuspid valve surgery is that the mortality is around 10% at 30 days. And perhaps most importantly, that most centers are not really doing tricuspid valve surgery. 0.56 isolated tricuspid valve surgeries per operative center in the United States, or per cardiovascular operative center in the United States. And less than 1% of all cardiothoracic surgery programs do more than 5 isolated tricuspid valve surgeries per year. So it is just not commonly done. And that, what at least my experience is, that you know cabbage surgeons, and you know a VAD surgeon, and you know an aortic surgeon, and you know a mitral surgeon, but you don't know a tricuspid valve surgeon. They just nobody's sort of raised their hand for that one. And there are sort of people who do valvular surgery very well. They do tricuspids, of course, but nobody sort of like staked their name on that, at least that I'm aware of. And the data would suggest that. If you look at using the NIS data, again, a US sample, so slightly younger population of people, this excludes congenital and endocarditic patients. So we're talking about symptomatic TR and isolated therapy. You can see that the volume of surgeries represented in red and blue have gone up over the years. Mortality has hovered right around the same spot at 8.8 or 9%. This population was age 62. Length of stay in all of these trials is over 10 days. It's between 10 and 14 days usually. So complex patient population, a signal that particularly if the RV has started to fail, these are really hard people to kind of be able to get through their operative course. And if you look at any using STS database, if you look at any tricuspid valve surgery, even if it's associated with a left-sided surgery or a CABG or whatever, again, operative mortality in that 9 to 10% range. Most of these surgeries are in addition to a different valve at 85% or so. And congestive heart failure continues to be kind of this signal that those are folks who have a hard time getting through the surgery, which is a challenge because we're waiting for these people to be stage D and have dyspnea and have edema, right? So if you're waiting for them to have heart failure and then you say, well, surgery doesn't work very well if you have heart failure, like you've set up a bit of a paradox for the surgeons, right? To come to their defense. So tough space. And what's kind of amazing about this is that all we've talked about with surgery so far is the risk, right? I haven't told you a single thing about whether it works. And we'll skip this one, but it's just another one about reoperation for tricuspid valves, 10% mortality again. So very consistent numbers. That's the point. When I tried to just figure out like, well, does it work? Like, is it effective to help people live longer? I could actually not find any data on this. There's one Mass General trial that they're wicked smart in a Mass General, and they decided to do this thing about using immortality bias to adjust in this population, because the idea being that if you are watching someone with tricuspid valve disease and you watch them to death, how does that sort of, how do you incorporate that? And if you survive to get a surgery, when does the clock start? Anyway, it's not, we shouldn't spend too much time on this. But the point is that there's very little data on whether or not tricuspid valve surgery is effective at altering the course of people's lives. In terms of longevity, specifically, not quality of life, but longevity. And at least in this one trial that I could find, there really isn't evidence that it sort of moved the needle a whole lot. So we'll take that for what it is. All right. This obviously set the stage for transcatheter therapies to kind of step in, right? And because we have a scenario where there's lots of tricuspid valve disease, there is, kind of a gap in our understanding. So the world's our oyster to sort of add science. There's not a high penetrance of surgical intervention. So which is, from a catheter-based standpoint, means we don't have a lot of antecedent knowledge, but there's an opportunity to really kind of flush some things out. To start, there were a whole lot of EFS trials on a whole lot of therapies, all of which were sort of like, let's just throw things at the wall and see what sticks, right? So you had some tier stuff with Clip and Pascal. You had some early valves. You had a spacer thing with Forma, which is just a buoy that sat in the middle of the tricuspid. You had an annuloplasty system. This is a pledget. You had heterotopic valves. Everyone's just throwing everything at the tricuspid valve to see what stuck. And then you had small populations. So there's one meta-analysis that sort of tried to lump all of those therapies together and just said, like, well, if you are successful at improving the tricuspid valve, does that help, right? And they used a control cohort of patients who were not at institutions who didn't have anything to offer and just watched their patients with severe TR, right? Created propensity matched pairs. You may agree with that strategy or not. I don't love propensity matching personally, but it works sometimes. And what they said was, okay, we're gonna divide into 3 categories. We've got our observational control cohort, that's in red. We've got our therapy that kind of worked, that's in blue. And then we tried therapy and didn't work for anything, and that's in black. Right. So the population represented by the black circle is, they got a Forma and it did nothing, right? But they got a therapy. Whereas the blue is, maybe you got a Clip and you got a 2-grade reduction and now you're moderate or less. And what they found essentially was that the population in whom TR was substantially reduced appeared to live longer and better with less heart failure than the population who were treated unsuccessfully, let's say, or the population who weren't treated at all. Okay. So kind of comports with our preconceived notions of what we want tricuspid valve therapies to be. And one of the things that was really striking about this study for me, at least, was the mortality rate at 1 year, right? Even in the successful group, the 1 year mortality was 22%. And in the unsuccessful group was 36%. And for years we've been saying, well, like, I don't know, maybe just the tricuspid valve's not that important, right? But we're seeing I mean, tricuspid valve not that important, and you see a 5% 1 year mortality, like, okay, maybe, these people are older, 5% mortality kind of fits, but 22, like 1 out of 4, that's a really startling number. And in fact, when we go back and look at the Tel Aviv data that I showed you early, right, 45% of the people with severe TR at 1 year were dead. Really high numbers. And so we've got these, this is all coming out. We've got these 2 randomized trials that are starting to percolate through, one for tricuspid clip and one for the evoke valve. And you're starting to say, like, whoa, we can see 1 year mortality at 1 out of 4. Like, this really could be a home run, right? And I think that was sort of how everyone was anticipating the randomized trial data to come out, was that we were looking for mortality. And we'll speak to that more, but that was the context. So currently, I'm going to talk just about transcatheter replacement and edge-to-edge repair, because those are now FDA approved. They have the most data. I think they're kind of the most interesting. Theoretically, heterotopic valves are also available to your patients. I mean, we were doing them in 2016 by putting in tracheobronchial stents in the IVC and then an Edwards valve inside that. So it's been around, but as always, like, sort of a terrible palliative thing. So we're really going to focus on the 2 in purple, okay? And we'll start with the evoke valve. The original plan for TriScend 2, and you're probably all familiar with this, they were aiming for 775 patients with 2-to-1 randomization against optimal medical therapy. And then you can see the endpoints. What's amazing about this was that they actually got FDA approval with 150 patients in 6-month data, using a breakthrough designation with the FDA. So they never really came close to their original intention of 775 patients. And in fact, the data still hasn't been published. They obviously released a lot of the information at TCT last year. So we have, those slides that were presented by Shio Kadali, but the actual manuscript has not been published, and the 1-year data is not even available. They just presented on 6-month data. So the mortality stuff still isn't there. But what they showed was essentially that the evoke valve is really good at reducing TR, right? It is, it works in that regard. You have 98% less than or equal to moderate TR, and that's 94% if you take out moderate. So mild or less TR, 94%. So that's successful in that regard. But you can see these numbers. I mean, they're quite small, really, given what the original intention of the trial was. And when you look at the primary safety endpoints, I think there are some interesting things here. You see 14% pacemaker rate, which is not a trivial number. Otherwise, I think, cardiovascular mortality was 3. They don't have it again. That's at 6 months, and they don't have it against OMT. So we're still, waiting on that publication. But certainly that's not a 25% number that we saw out of the meta-analysis or out of Tel Aviv. So a lot lower mortality information than expected. Right? You guys are probably quite familiar with how this works, but I will just say that it is not a total cakewalk, and it's certainly not TAVR. It's a real pain in the bum, and you mostly just stand around for 3 hours while someone tells you whether or not to turn the knob a quarter turn. I quite hate this procedure, but it is effective. So and the imaging is really critical. So having good imagers is absolutely important. And then it is a self-expanding outer and inner cage system. The anchors are meant to hook underneath the in the subvalvular structures. That's kind of how it works. Looks like a little bit of a volcano when you are on the sort of en face view from the tricuspid valve. But it's, it will reduce massive or torrential TR into something that is not massive or torrential. So in that regard, it is very effective. And we'll see where that goes. TriLuminate, I think, is actually in tricuspid clip in general, I think is actually a much more interesting population because there's a lot more grayscale in how things go. And they actually, saw their trial all the way through. So 350 patients, one-to-one randomization against medical therapy. The one-year results have been published in the New England Journal, as you're all familiar. And I think it's fair to say that though it was, it is a win of a trial, at least, by the letter of the law, most people were a little disappointed, I think, in how kind of it all washed out. Mostly because of this, that the death really didn't change at 1 year. And we had all this information coming out that was like, a fourth of people are going to be dead. And in the optimal medical therapy group, they're just going to be dropping like flies, like walking into clinic, fall over dead. And you're like, you count. And, it didn't go like that. I mean, it was 9% mortality in both arms. And that was a lot different than was expected. This Finkelstein-Schoenfeld analysis, if you're not familiar with it, basically they took everyone in the as treated arm and every single person in the OMT arm, and they created a matrix where each person was head to head, and then decided who you would rather be between the two. So it creates a lot more outcomes to analyze, and that's how they kind of came to this win ratio of 1.5, largely driven by quality of life scores. Right, which are not a hard metric. They're validated, but we also have some subjectivity to them, let's say. And then 10% mortality. So how did the quality of life work? Well, it turned out that if you were successful in driving the TR down substantially with TR, people felt better. So that makes sense. And a KCCQ-12 score of 18 is in line with TAVR, basically, just to sort of give you some frame of reference. TAVR, kind of time and time again, has a KCCQ of about 20. So 18 is pretty good. And it turned out that if you, really weren't effective, you didn't get a lot of benefit, which makes sense. Now, I think part of the mortality thing, one of the arguments that's come up is that, well, you've got a trial population, it's not a real world population. So they really sort of they chose people who are too healthy for their trial. You may have heard that at some point or another, because that's been the sort of common refrain. There have been some data looking at, if you go to Germany and Switzerland where tricuspid clip is available, and they look at just some high volume centers and all the people that they just commercially treated, what percentage could have been enrolled in TriLuminate? Turns out to be just over half. And then if you segregate them by could they have been enrolled or could they not, that people who are not died more commonly. So that does support the idea that the TriLuminate perhaps kind of shot itself in the foot by erring towards the null in picking too many healthy people or disqualifying unhealthy people. But that's still, I think, a little bit too TBD, and does draw some questions about whether or not the observational data was really right, or if it was just confounded, as a lot of observational data is, right? So I want to just share one patient story with you. An interventional cardiologist can't give a talk without at least one patient story, and I've just held it to one. So in 2016, I was referred to a lady for severe aortic stenosis, and she had a little bit of TR at the time, and her brother was an emeritus professor at Johns Hopkins. And at the time, we had the PARTNER 3 trial. And at that time, 2016, people were shopping for TAVR, right? If you were a 78-year-old who is healthy, and you would go to a site and say, we had all these people dropping out of partner 3 if they got randomized to surgery. I mean, they were just bouncing around. But not this woman. She was like, my brother tells me this TAVR thing is too new. We're not doing TAVR. We're doing something that has more, is more robust. And so she declined partner 3 and she went on to surgery. She got a Percival valve, which I find incredibly ironic because the level of data around a Percival valve is so much less than but class effect being what it is, she got a sternotomy. So that was what she wanted. 2018, unfortunately, she did have some post-op AFib that was new, and that turned into basically sort of predominant AFib. And time goes along, and a couple years later, so now 5 years later, actually, she gets referred back to me for her severe TR, presumably atriofunctional TR. And she comes to my clinic and she's like, well, listen, I want you to talk to my brother. And I was like, oh boy, here we go. This is the guy who thought TAVR was too new in 2016. And we're in 2021. There's no data right now. Like, we've been doing it because we're like, well, maybe it helps and we get referred these people and we're trying our best and we're learning, but I'm going to call this guy and he's going to chew me out. And so I called him, and he, it turns out, is just a gem of a human being, the nicest, sweetest man in the world. It also turns out he had been studying during his working time, he was studying RV-LV coupling in dogs. And that was his life. His last name is different than her last name. So that's him. And I'll show you that. But he studied RV-LV coupling, and he was like, by golly, I am so excited for you to treat my sister with tricuspid clip. This is going to be the best thing since sliced bread, like blah, blah, blah. And he goes on and he's telling me equations about how the coupling works. And I am totally lost. I mean, it's all over my head. It's a Saturday morning. I'm standing in my driveway talking to this guy, sort of out of obligation to this lady and thinking that he's going to yell at me. And I was like prepared. And then he was like, this is great. When can you do it? I can't wait for this. This is good. She needs this so badly. And I was like, this is such a weird sort of dichotomy with the TAVR thing, having data, but not enough data. And now this, just somehow it played right into sort of what made sense to him. So I obviously wouldn't share with you the story if I did a terrible job with the tricuspid clip, but so she got 2 clips and it was very effective. And we got her, TR down quite substantially. And then at 30 days, it was still, it's there, but it's mild. And, she remains a good story. And I want to, because we see her again. But before then, it is, I do think that I've come to appreciate his points a little bit more, because I showed you that last slide, it was just some color jets, right? And everyone is sort of satisfied with that. And we've been satisfied with just color Doppler and being like, you know what? It's too much color, less color. That's great. We're awesome. We are anti-color. But there's obviously so much more to it that we haven't wrapped our heads around. And so this is a different patient, but just a really good example of this. So you have a lot of color, but you also have V waves that are almost to 50, which is a very unusual for a right atrium. Right atrium tends to be a high compliance, high capacitance area. So V waves don't tend to go up that much. You have hepatic flow that is very reversed and fast. And you have pulmonary vein flow, which is not something that I think people tend to think a lot about when they think about the tricuspid valve. But it turns out that if you have a lot of tricuspid regurgitation, you're subtracting it from your forward circulation, right? I mean, it makes sense. So in this case, we did a series of clips, and there's still a lot of color. Now we've got these eccentric jets. It's not my best work. I mean, I'm not sending this one home to mom, but it was what I could do. And so we did it. But what we saw, despite these kind of weird eccentric jets, is that you have V waves that have diminished substantially. The pulmonary vein flow is not perfectly normalized, which is a very difficult task to achieve, I must say, after a few hundred of these cases. But it is clearly blunted in reverse and a lot slower. And most interesting to me, because we keep seeing this, is that the pulmonary vein flow velocity increases almost 3 to 4x. And you see these people where the pulmonary vein flow really jumps, even if the color is not perfect. And those people feel better. They just do. They have more forward flow, right? I mean, of course they feel better. You've augmented their forward circulation. And that is something that we haven't really been paying a ton of attention to, but I think is actually very important. And we've gone back to try and, study all our patients and correlate this to quality of life scores and other things that we have just observationally tracked over time. And so we're going to hopefully have more information about this in the future. But that was the point of the sort of professor's point, is like, it's not just about color. We need to you need to augment forward circulation. And now, as it comes to CLIP specifically, we do have a little bit more information about durability. And this is, I think, a weak spot for TEER, which is that even though most people had a preserved result at 2 years, no one was coming off their diuretics. And I will say that patients are really disappointed to not come off their diuretics. Everyone hates diuretics. They can't go to a bus, they can't go to their bridge game, or they're pee all the time, whatever it is. So this is something that is kind of a rate limiter for edge-to-edge therapy alone, which is that even if it is durable, and I'm not so sure it's really all that durable, but even if it is durable, you need to be really fastidious about your GDMT or at least your diuretics. And as for our lady, so she had atrial functional TR, right? And we brought her back for a Watchman actually not too long ago, just last month. And just incidentally, we're kind of scanning everything, and her TR is worse. This is 3.5 years later. And it makes sense, right? Because even in the TriLuminate 2-year data, the ventricles got smaller, but the atria continued to get bigger. So if you have atrial functional TR, the way that this works is not uniform dilation, in my estimation. What we're seeing is that if most of the time people are getting clips to the anterior septal commissure, because that tends to be where we can really work the best with the current generation devices, but you can dilate in any vector, right, or any axis. So if you have essentially kind of bicuspidized the valve, which is a very common strategy for tricuspid edge-to-edge repairs, to just sort of close off this entire anterior septal portion, pull over the anterior free wall. The septal doesn't dilate, right? It's septal, it's attached to the LV. But what can then happen is you just get more dilation posterior if the nidus for that dilation is unchecked, right? That's my hypothesis anyway. And there is some argument that Europeans are sort of putting what would otherwise be a bit of a on the way out clip on the posterior septal, just to sort of try and bridge that for the future. I haven't really adopted that strategy myself yet, but maybe they're right. I don't know. There's just so many things to learn still. So when it comes to these transcatheter therapies, I think we're just starting to understand the pros and cons of all of them, right? The transcatheter replacement really works well to abrogate the TR and is pretty successful. Whether or not it's too stiff for the RV, and we're seeing some evidence of maybe TAPC going down, just kind of a little bit of a worry that as you put in this big device, you drop the TR, the volume decreases, the RV shrinks, and now a device that was 7% oversized is now 27% oversized because it didn't change size. And what does that do to your right ventricle, right? So there's some things there. You might need anticoagulation for life. And as interventional cardiologists, we just spent the last 10 years being like, don't get a mechanical valve. How dare you? You get anticoagulation. That would be so bad. And you need a Watchman. And then we're like, you know what? It's no big deal. Just take a little anticoagulation for this valve. Like, what do you care? Really very hypocritical. On the edge-to-edge repair side, I think the safety profile is kind of is unmatched. It's really a safe procedure, and that's what we've been saying for years now. In my practice is basically like, we don't know if it's really going to help you, but it's not going to hurt you. The safety is really very good. It's familiar. People who do MitraClip kind of understand at least how mechanistically how the device works. There's no anticoagulation. However, it's very demanding and reproducibility is low, and durability is unknown, right? You got these heterotopic valves and some of the other things that are trying to lean into the ease of use space. But you know, what happens when you ventricularize the atrium? I mean, we didn't even touch on that because I don't think we're ready to even explore that just yet, but the space is just wide open. I guess that's the point. So to wrap it up, oops, sorry about that. So TR is prevalent and it's mostly secondary. There is inferential data that it is culprit and not bystander, or at least that it's an excess, that it's also bad, even if it's not the culprit, right? The RCTs hopefully will tell us a little bit more about that. You've got guidelines with no mortality benefit to med therapy. You can treat the primary issues if there is a primary issue. You can consider surgery. Surgical therapy is a very low penetrance. Mortality seems to hover between 8 and 10%, particularly in those patients with heart failure to start. And there are no randomized control trials of isolated TR surgery. And then on the transcatheter side, we pinned a lot of hopes on our first ever RCTs of isolated tricuspid valve therapy. And, you know, it's a start, but it's just that, it's just a start. And new therapies are popping up like rabbits, and they're challenging a lot of our conceptions of how tricuspid valve should or shouldn't work. So it'll be really interesting space to continue to grow into. And for now, this is, I think, the world as I understand it anyway. So thank you very much for your time. I appreciate the invitation to be down here. I appreciate all of you making it despite a recent tornado. Thanks.